Good morning all. Today we are going to discuss QRS wave. Alright. So we have discussed P wave, that is a atrial depolarization wave earlier, right? So after the atrial depolarization comes the AV nodal depolarization. Now what happens here, the property of AV node is to slow down the impulses, to hold the impulses for some time, and that we know it is very necessary so that the atria get time to send the blood to the ventricle and ventricle get time to fill before the depolarization wave comes into the ventricle, and then ventricle will contract so that cardiac output will be effectively produced. So AV nodal depolarization is slow and it is so small in amplitude that it is not caught on the electrocardiographic paper. So that is why it will produce a flat line or isoelectric line, and since this was P wave and this is the QRS which is representing the ventricular depolarization, this is called PR segment. So PR segment represents the AV nodal depolarization. Alright. Why don't we call it PQ segment? Because Q wave presence is not necessarily, it is not necessarily present in all the leads all the time. So that's why by convention it is called PR segment. Then now today's topic is QRS interval or QRS wave. Alright. So this QRS represents a ventricular depolarization. It represents total ventricular depolarization. So first wave is Q wave, right? Now from the AV node, the depolarization impulse travels into the ventricle. So it will first travel in the bundle of His, and then through Purkinje fibers it will activate the ventricles from endocardium through myocardium up till subepicardium transversely, and both ventricle will contract at the same time. So any lead which is recording the depolarization is actually recording the resultant net vector which is directed either towards that lead or away from the lead, right? Now we know that the ventricular depolarization takes place in 3 stages. The first is septal depolarization, okay, interventricular septal depolarization. Now septal, since upper 2/3 of the interventricular septum is fibrous, so the septal depolarization will start from the branch of left bundle from the left side. Alright. So the septal depolarization, since it is only in the lower part now, so very small chunk of muscle is remaining. So it is very low in amplitude. It is not a very strong factor, strong vector. So this septal depolarization is from left to right, okay, and a little bit towards the anterior lead. So if we look at the V1 lead, V2 lead, V3 lead, and then V4 and V5 and V6. Now I am talking about the chest leads. Now you know the V1 is towards the right side, V2 and V3 are literally over the septum, okay. So this V1, V2, V3 will sense this septal vector as if they are coming towards it, right? So V1, since V1 is since little away, so V1 will record a very small positive deflection. This is R wave, right? So septal depolarization is recorded as R wave in V1. And then there is major ventricular depolarization. So both ventricles are contracting. And since left ventricle is the most prominent and powerful muscle, the major ventricular depolarization is leftward and downward. So second part, that is the major ventricular depolarization, is sensed by V1 as it is going away from it. So it will record a deep S wave. So very teeny mini R wave, which is a septal depolarization, and S wave, right? So it is not recording any Q wave. Now when we come to V5, V6. Now what is happening? V5, V6 are on the left side. Now septal depolarization is from left to right. So V5, V6 lead will sense this septal depolarization wave as if it is going away from them. Now since septal depolarization is a very small magnitude, so these leads will record an initial small negative deflection, that is Q wave, right? Now the major ventricular depolarization is down and left, that means V5 and V6. So now the major ventricular is towards them. So they will sense this major ventricular depolarization as if it is coming towards them. So any lead, any vector which is going towards the lead will record a positive deflection. So now they will record a very tall R wave, right? So this is going to record a small q and tall R wave, V5 and V6. So since V5, V6 are left leads, similarly in limb leads, 1 and AVL are also left leads. So 1 AVL, V5 and V6, these are the usual leads which record Q wave. Now these Q waves are physiological in these leads and they represent septal depolarization. So, so this is about the Q wave. Now second part was the major ventricular depolarization, which is recorded by V1 as an S wave because that depolarization is down and left, which is away from the V1 lead. And when it comes to V4, V5, V6, it will sense as a positive deflection, so a tall R wave will be subtended. Then comes the last part of the ventricular depolarization, and that is the basal ventricular depolarization. Basal. So first was septal, next was major ventricular depolarization, and the third one is basal. This is the first, this is the second, and this is the third. So the basis, you know, the net resultant vector of the basal depolarization is again little rightward and anteriorly from left to right. So if we look at the left side lead V5, V6, it senses as if that small vector is going away from it. So it will record a negative deflection but very teeny mini deflection, right? So first negative is Q, then there is R, and the second negative is S wave. So this is the QRS complex. So Q represents, in the V5, V6 lead I am talking about, it represents a septal depolarization which is moving away from V5, V6. R wave represents major ventricular depolarization which is moving towards the V5, V6. And S wave represents a small vector of basal ventricular depolarization which is moving away from V5, V6. So in nutshell, in QRS complex, the Q wave is a first negative deflection after the P wave. R wave is a positive deflection after the Q wave if it is present. If it is not present, after the P wave. S wave is a second negative deflection after the R wave. Negative means it should go below the baseline. Positive means it should go above the baseline. So what is the duration of the QRS? How much time it takes for ventricles to depolarize? So P wave, I said 2.5 small segments. So you just remember 2.5 small segments. AV nodal depolarization, that is PR segment, that is also 2.5 small segments. 2.5 means 0.04, 0.04 and 0.02. So that will be around 100 milliseconds or 110 milliseconds. That is the maximum limit we are talking about. So 110 milliseconds, 110 milliseconds, and even QRS is maximum 2.5 small segments. That means 100 milliseconds. So all three are 2.5 small segments. So it's very easy to remember like that, right? 2.5, 2.5, 2.5. So remember P wave is 2.5, PR segment is 2.5, and QRS is 2.5, right? So that's very easy to remember. So that will be around 100 milliseconds. So that is the QRS duration. Now, okay, before I go to Q wave right away, just let me tell you one thing, or let me request you one thing. Kindly subscribe to my channel. I am Dr. Seema Kale, Senior Physician Consultant in Delhi. My special interest, as you can see, is electrocardiogram and teaching. Electrocardiogram teaching and learning also, of course, on the way. And please press on the bell icon for all, so that you will get notifications. And if you subscribe, I would be more motivated to continue my working. Thank you very much for that. So we go ahead now and we will discuss now Q wave, right? So we all have heard that Q wave represents myocardial infarction. So everybody knows Q wave means myocardial infarction. But then we have seen that there are normal Q waves also, right? So on the left leads, we will record a normal Q wave, 1 AVL, V5. But how much is the normalcy? What is normal? So normally Q wave should be less than 25% of the preceding succeeding R wave. So Q wave should be less than 25% in the height of the succeeding R wave. This is a normal Q wave. Secondly, it should be less than 2 millimeter in depth, right? So it should be very small. And 2 millimeter means 2 small segments, but it should be very narrow. So it should be like really less than 1 small segment. So 1 small segment is 0.04 seconds. It should be actually less than half of that small segment. So it should be around 0.02, 0.03. It will like, okay, that's okay, but it should be less than that. So it should be less than 0.03 seconds in most of the leads, right? Then in V1, V2, V3, since V1, V2 are little on the right sided leads on the septum, so they are recording the septal depolarization as a positive deflection, right? So in V1, V2, V3, they should not have Q wave. So Q wave in V1, V2, V3, especially in V2, V3 is abnormal. So Q wave is not normal in V2 and V3. V1 can have a Qs complex. Qs means a totally deep negative complex. That means it may not record a septal at all if it is little placed higher up. So Qs complex in V1 will do, but Qs complex in V2 is abnormal. But so Q wave in V2, V3 is not normal. Alright. Then normal Q waves will be there in 1 AVL, V5, V6. So 1 AVL, V5, all the left sided leads will have a normal Q wave, which is 1 small segment or at the most 2 millimeter in depth, and certainly less than half of small segment in width. That means 0.02, 0.01 like that, or at least less than 0.03 seconds. And in V4, only in V4, the Q wave should be even less than 0.02. So that is the cutoff for V4 lead. So in V4, Q wave should be less than 0.02. Normally it should be in all other leads, it should be less than 0.03 seconds. That means less than a part of one small segment. And in V4, it should be less than 0.02 seconds. These are the normal parameters of Q wave. And what about lead 3 and AVR? Lead 3 and AVR can have any level of Q wave, okay? Isolated Q wave in lead 3 and AVR is normal, which can be of any dimension. Because many people come saying that we have been reported as inferior myocardial infarction looking at only Q wave in lead 3. So that should not be considered as myocardial infarction, and you should always look at the symptoms of the patient. And for myocardial infarction, you should have changes in consecutive 2 leads. So we don't give importance to Q wave in lead 3 and AVR. And whenever you see some small Q waves in lead 2 along with lead 3, no symptoms, always ask the patient to take deep breath like this and hold for some time and take the ECG. You can yourself see in the monitor of the electrocardiograph, that machine, that the Q wave reduces by at least 50% of the size. So these are respiratory Q waves. These are due to diaphragmatic respiratory variation. So you should remember that Q waves are normal in lead 3 and ABR. So that is all about the Q wave. So I just revise one more time. Q wave represents septal depolarization, and they are less than 25% of the height of the QRS complex. They are less than 2 millimeter in amplitude, and if they are more than 2 millimeter, then they suggest abnormality. In most of the leads, they are less than 0.03 seconds, but in V4 they should be less than 0.02 seconds. Okay, and V1, V2, V3 should not have any Q waves. QS complex will be okay in V1, but certainly not in V2. That will suggest some abnormality. Then that's all, I think. That's all. So next time we will discuss the progression of the QRS complex, how it progresses from V1 to V6, and we will discuss the T wave, that is the ventricular depolarization wave. So this will leave for next, and then subsequent we will be discussing intervals and segments. So for today it's enough, and I take your permission to leave. And Jai Bharat, Jai Hindustan. Thank you. Jai Hind.